This podcast is brought to you by the erythropoietin EPO level test. This isn't just a number, it's the digital readout of the bone marrow's current marching orders. When your body's oxygen sensors whisper, "We need more," EPO leaps into action like an overzealous general, screaming, "More red blood cells! Build more! Now!" In erythrocytosis, this general often gets a bit carried away, flooding the system with new recruits until your blood resembles a rush-hour traffic jam. It's truly a test that reveals whether your body's oxygen alarm system is simply working overtime, or if someone has accidentally left the EPO faucet wide open.
Welcome back to The Deep Dive. Today we're diving into something right at the heart of your work as a medical laboratory scientist, erythrocytosis. You know the situation. The sample arrives, the RBC count is sky high, and you immediately think, okay, what are we dealing with here? Is this simple dehydration or something much bigger?
Something potentially serious.
Exactly. So our mission today is to really arm you with that detective's toolkit. We want to unpack the pathophysiology, the why behind the different types of erythrocytosis, and critically, how your lab tests guide the whole diagnostic process and patient management. Think of this as a shortcut to understanding what those numbers really mean on your screen day in, day out.
That's a great way to put it, because at its core, we're talking about an abnormal increase in red blood cells, the RBCs, and that naturally bumps up the hemoglobin, HGB, and the hematocrit, HCT. You might also hear terms like polycythemia, maybe even erythemia, though that's less common. But the key thing is it's not just one disease. It's a condition with this really broad spectrum of causes. Some are pretty benign, others life-threatening.
And for the patient, what might they be feeling?
Well, symptoms can be things like ongoing headaches, maybe dizziness, and often that really bothersome itching, the pruritus.
Okay, let's start breaking this down. Classification seems key here. We hear about relative and absolute erythrocytosis. What's the fundamental difference? How do we tell them apart?
Yeah, this distinction is absolutely crucial, especially for us in the lab. Relative erythrocytosis, it's really an apparent increase.
Apparent? How so?
Think of it like this. The actual number of red cells in the body hasn't changed, but the fluid part of the blood, the plasma, has gone down. So the red cells that are there just seem more packed together, more concentrated. It's kind of an illusion.
Ah, okay, like less water in the pool makes it look like there are more swimmers.
Exactly. Whereas absolute erythrocytosis, that's the real deal, a true increase in the total red blood cell mass. The bone marrow factory is actually churning out more red cells.
Got it. So relative is this apparent thing, more about concentration, almost like a dehydration story.
Precisely. It's hemoconcentration, not true proliferation.
So what kind of things cause that plasma volume to drop?
Well, the most obvious one is just not drinking enough fluid, simple dehydration. But it could also be excessive fluid loss, think severe vomiting, diarrhea, maybe overuse of diuretics.
Burns too, right?
Yes, extensive burns are another cause where plasma leaks out. Anything that depletes that plasma volume makes the red cells look relatively higher.
And within this relative bucket, there's this specific type, stress erythrocytosis, Geissbach syndrome. Sounds a bit different.
It is interesting. It's often seen in middle-aged men, typically those who might be obese, hypertensive, smokers, often living high-stress lives. The exact mechanism isn't totally pinned down, but the thinking is it might involve increased catecholamines in stress hormones. They might cause fluid to shift out of the blood vessels, decreasing plasma volume. So yeah, stress and anxiety seem linked.
So for the MLS listening, this is where you come in. How do we spot relative erythrocytosis in the lab results? What's its unique signature beyond just high HGB and HCT?
Okay, key point here. You see the high HGB, HCT, RBC count. Your first thought might be more cells. But for relative, the crucial finding, though hard to measure directly sometimes, is a normal total red blood cell mass.
Oh, wait, the gold standard if you can get it.
Exactly. But practically, what else? Look at serum protein and albumin. They might be normal or even high.
Ah, because of the concentration.
Precisely. It's a clue it's a fluid issue. And critically, the erythropoietin level, EPO, it'll be normal or maybe low normal. The body isn't trying to make more cells.
And oxygen levels?
Oxygen saturation, SO2, should be perfectly normal. These findings together really help you differentiate it.
That's super helpful. So relative is the apparent increase, the plasma issue, but absolute, that's the true increase in red cell mass. How do we then break that down?
Right. Once we know it's a genuine increase in total red cells, absolute erythrocytosis splits into two main categories, primary and secondary.
Primary and secondary.
Getting this right is vital. Primary means the problem is intrinsic to the bone marrow itself. It's just gone rogue, producing too many red cells, usually without needing EPO signals. Secondary means something outside the bone marrow is driving the production, usually by stimulating EPO release.
Okay, primary. This is where it gets really interesting for the lab, right? Because now we're potentially talking about myeloproliferative neoplasm, a type of blood cancer.
Exactly.
And the big one, the one we really need to know, is polycythemia vera, PV. Let's unpack PV from a lab perspective.
Okay, PV. It's a chronic myeloproliferative neoplasm, or MPN. You get this uncontrolled clonal growth of all the myeloid lines, red cells, white cells, platelets. But the increase in red cells is really the most prominent feature.
And what's causing this uncontrolled growth?
In the vast majority of cases, over 95%, it's a specific mutation in the JAK2 gene.
The JAK2 mutation, we hear that a lot.
We do. This mutation causes what we call constitutive activation of the EPO receptor pathway. Basically, the pathway is always on. The red cell precursors just keep getting signals to grow and divide, even if there's no EPO around. They don't need the external signal anymore. The switch is stuck on.
Wow. Okay, so the factory is running full tilt, nonstop. What does that actually feel like for the patient? Any really specific symptoms that might, tip us off?
Well, you get the non-specifics, headache, dizziness, fatigue, easy to brush off.
Sure.
But then there's the pruritus, that itching, especially after a hot bath or shower. That's pretty classic.
I've heard about that one.
Some patients get erythromelalgia, burning pain and redness, often in hands and feet. Splenomegaly, an enlarged spleen, is common too, and the big danger really is thrombosis, blood clots, both arterial and venous. Very serious risk.
Okay, let's get to the lab findings for PV. This is critical. What does the definitive lab picture look like? What are we zeroing in on?
Absolutely crucial. You'll see high HGB, HCT, RBC count, often significantly elevated. But here's the kicker, the real aha moment for a diagnosis. The EPO level is usually normal or decreased, often decreased.
Decreased EPO with high red cells. That seems backwards.
It does, but it makes sense because the marrow is producing cells independently of EPO. The body senses enough oxygen carriers, so it dials back EPO production.
Okay, that clicks. What about other cell lines?
You might see increased white blood cell count, increased platelet count too in many cases. Remember, it affects all myeloid lines, just red cells predominantly.
And the definitive test?
The absolute smoking gun is a positive JAK2 mutation test.
Okay.
And if you do a bone marrow biopsy, you'll see a hypercellular marrow packed with increased numbers of erythroid, myeloid, and megakaryocytic cells. The factory is definitely overcrowded.
Right. So we've covered relative, the illusion, and primary, like PV, the rogue marrow. What about secondary erythrocytosis? That's a response to something else, right? What drives that? Still EPO?
Yes, in secondary erythrocytosis, the increased red cell production is driven by increased EPO. But here, it's usually the body's appropriate response to some underlying condition that's causing the EPO spike.
Okay.
The bone marrow itself is generally fine, it's just reacting to that external signal.
So a major cause is hypoxia-induced low oxygen. Makes sense the body would want more oxygen carriers. What conditions cause that chronic low oxygen?
Yeah, when oxygen levels dip persistently, the kidneys sense it and ramp up EPO production. Think chronic lung diseases, COPD, emphysema.
Okay.
Living at high altitude for a long time, obstructive sleep apnea is a big one too.
Oh, yes.
And certain heart conditions, cyanotic heart diseases where blood isn't getting oxygenated properly. The body tries to compensate by making more RBCs.
Then there are those more unusual cases, EPO-producing tumors. How does that work?
It's less common than hypoxia, but yes, certain tumors can ectopically produce EPO, meaning they make EPO when they shouldn't, outside the normal kidney control and unrelated to oxygen levels.
Like rogue EPO factories.
Exactly. Examples are renal cell carcinoma, kidney cancer, hepatocellular carcinoma, liver cancer, and hemangioblastomas, often found in the brain or spine. Finding these needs some good detective work if the EPO is high without hypoxia.
Any other causes of secondary we should keep in mind? Things that aren't hypoxia or tumors?
Definitely. Exogenous EPO administration, think athletes, doping, unfortunately.
Right.
Also, androgen use can stimulate RBC production. Certain medications can do it. And there's a specific thing called post-kidney transplant erythrocytosis. So it's a fairly broad list to consider.
Okay, so for the lab, how do we distinguish this secondary type from PV or relative? What are the key lab signals?
You'll still see the high HGB, HCT, and RBC count. That's the common thread. But the major differentiator here is usually an elevated EPO level.
Elevated EPO. Makes sense if something is stimulating it.
Right. The big exception, of course, is if someone's injecting EPO. Then their own EPO production might be suppressed, so the level could be normal or low despite the high red count.
Good point. What about other counts?
WBC and platelet counts are typically normal, maybe slightly up, but usually not the significant increases you might see in PV. If it's hypoxia-driven, an arterial blood gas analysis will likely show hypoxemia, low oxygen.
And for tumors?
If a tumor is suspected based on high EPO without hypoxia, then imaging, CT scans, MRIs, becomes essential to actually find the tumor.
Okay. This is where it all converges for the medical laboratory scientists. We've got the different types, their mechanisms, their lab clues. How do we in the lab use all this to help build the diagnostic picture for the clinician? How do we piece it together?
Your role is absolutely central here. It's like providing the map for the clinician. The approach is systematic, heavily reliant on your results. First, obviously, confirm the erythrocytosis. Check those HGB and HCT levels are truly elevated according to reference ranges. Step 2, rule out relative erythrocytosis. Look at the clinical picture, hydration status, check those serum protein and albumin levels. Are they high, suggesting concentration? And if you can measure red cell mass directly, that's the gold standard to separate relative from absolute.
Okay, relative ruled out or in. What's next?
The pivot point. Measure the serum erythropoietin, the EPO level. This result really directs the next steps.
How so?
Simple logic. If EPO is low or normal, it strongly suggests a primary cause, like PV. The marrow's working overtime despite low signals. If EPO is elevated, it points towards a secondary cause. Something is telling the marrow to make more cells.
Got it. So we follow the EPO trail. If it's low or normal, then the next logical step is the JAK2 mutation test, highly likely positive in PV.
And if JAK2 is negative,
Then you have to consider rarer primary causes, other MPNs. A bone marrow examination might be needed then for morphology and other clues.
okay, and if the EPO is elevated, then you investigate the why. Assess for hypoxia, arterial blood gases, pulse oximetry. Look for reasons for low oxygen. Simultaneously, or if hypoxia isn't found, evaluate for those EPO-producing tumors with imaging. And always keep in mind the other secondary causes: exogenous EPO use, androgens, medications, transplant history.
That lays it out really clearly. Connect this back for us. Why is getting this diagnosis right so critical? What are the real dangers if erythrocytosis isn't managed properly?
Oh, the complications are significant. It's incredibly important. The biggest risk is thrombosis, blood clots.
Because the blood is thicker.
Exactly. Increased viscosity, sometimes abnormal platelet function too. This can lead to stroke, heart attack, PE, DVT, really devastating events.
Life-shortening stuff.
Absolutely. And paradoxically, some patients, especially with PV, can have issues with bleeding despite high platelets due to abnormal function.
Weird. High cells, but bleeding risk.
It happens. Also, splenomegaly, the enlarged spleen, is common from filtering all those extra cells. And long-term, particularly in PV, the bone marrow can become scarred, fibrotic, that's myelofibrosis, which can then lead to low blood counts. And there's even a small risk, again, mainly in PV, of transforming into acute leukemia down the line. So the stakes are really high for accurate diagnosis and management.
So briefly, how does treatment differ based on the type? Just to give us context for why our testing is so crucial.
Sure, for relative, it's simple. Fix the underlying cause, usually rehydrate. For secondary, again, treat the underlying cause, give oxygen for hypoxia, remove the tumor if possible. Phlebotomy might be used just to lower the HCT for symptom relief sometimes. For PV, the mainstays are therapeutic phlebotomy, literally removing blood to keep the hematocrit below 45%. Low-dose aspirin is almost always used to reduce clot risk, and then cytoreductive drugs like hydroxyurea or targeted therapy like ruxolitinib, a JAK2 inhibitor, are used to control the cell counts if phlebotomy isn't enough or for high-risk patients.
Okay, bringing it home for the MLS listening. If you take away just a few key lab tests from this deep dive on erythrocytosis, what are the absolute must-knows, the core toolkit?
All right, the essentials. First, your complete blood count, the CBC, HGB, HCT, RBC plus WBC and platelets. That's ground zero.
Okay.
Second, the serum erythropoietin, EPO level. Hugely important differentiator. Low normal, points primary, high point secondary.
Crucial.
Third, arterial blood gas analysis, essential to check for hypoxia. Fourth, JAK2 mutation analysis, indispensable for PV diagnosis.
The PV test.
Fifth, bone marrow examination for morphology, cellularity, confirming MPNs, ruling out other things. And sixth, imaging studies, CT, MRI, vital if you suspect an EPO-producing tumor. Those are your workhorse tests.
Fantastic. What a journey today, really digging into erythrocytosis. From the basic definition, sorting out relative versus absolute, primary PV versus the secondary causes, all through the lens of those vital lab findings. It just hammers home how critical your role as an MLS is. Your accuracy, your understanding, it directly guides patient care and diagnosis. You're truly central to figuring these complex cases out.
Absolutely, and it makes you think, which leads to an interesting question for you to ponder. As our diagnostic tools, especially genetic testing, keep getting better, what future advances in lab testing do you foresee? How might they further sharpen our ability to differentiate and manage these tricky erythrocytosis cases? How will technology change your impact?
That's a great question to reflect on. The field is always moving forward. Keep that thought with you as you continue your own deep dives. Remember, understanding the why behind your results makes your work even more powerful. Thanks for joining us on the deep dive. Keep learning, keep questioning, and keep making that crucial difference in the lab. We'll talk to you next time.